Welcome to the deep dive. Think of this as your premium tutorial into, well, one of the most critical systems in all of medicine, blood compatibility.
Exactly. We're going to be taking information that's, usually locked away in clinical guidelines and textbooks and really break it down.
And we want to give you that actionable knowledge so you can truly grasp the incredibly high-stakes science behind blood transfusion.
Today, we're definitely moving past the general knowledge you might have about blood types. We're going deep into the definitive, life-saving rules that clinicians use every single day.
And our source material for this is really top-notch.
It is. We're drawing from authoritative guidance on blood transfusion and compatibilities, specifically the kind of protocols used by places like the Royal Children's Hospital in Melbourne. These aren't just academic ideas, they are the absolute safety net.
So our mission today is pretty ambitious. We're going to break down the core systems. Everyone knows ABO and RH, but then we're going to crack the compatibility code.
Right, and that means getting into the real nuance, the difference between the best option, the perfect match, and what's just okay to use.
And crucially, what is absolutely, under no circumstances, marked never use. And we have to see how those categories shift depending on what we're actually transfusing.
Yes. Is it red cells? Is it platelets? Or is it plasma?
Yeah.
The rules are completely different for each, and understanding the why behind those rules, well, that's everything. It's the difference between a life-saving procedure and a potentially fatal one.
Okay, so let's start at the very beginning. The foundation. When you look at any of the source material, the ABO system is always called out as the single most important blood group system. So why? What gives it this, immediate non-negotiable weight?
The urgency really boils down to a unique sort of pre-programmed conflict in our bodies. The ABO system, it dictates which antigens, think of them like little identification tags, are on the surface of your red blood cells.
Okay, so you can have an A tag, a B tag, both, or neither.
Exactly. But here's the critical difference from most other blood systems. If you don't have a specific antigen, your plasma already contains the corresponding antibodies from a very young age.
So you don't need to be exposed to it first. It's not like getting a virus and developing immunity.
Precisely. It's an inherited, ready-to-fire immune system. Your body is perpetually armed against any blood cell it doesn't recognize as its own.
Right, so let's walk through that. If we take the four main groups, O, A, B, and AB, how does that internal logic work?
Let's start with Group O, because it's the perfect example of this dynamic, and the tables really make this clear.
Okay, so Group O red cells, they lack both the A and the B antigens. They have, you could say, a clean surface.
A clean surface, yes. And that's what makes their cells potentially the universal donor. But, and this is huge but, the flip side is that the Group O patient's plasma is armed to the teeth.
Because it doesn't recognize A or B.
Exactly. So it develops both anti-A and anti-B antibodies. Their plasma is just loaded with these weapons designed to seek and destroy A cells, B cells, and AB cells on site.
So if you give them anything but Group O red cells,
it's an immediate, catastrophic reaction. There's no negotiation.
And then on the other end of the spectrum, you have the universal recipient, Group AB.
Right. And their situation is the complete opposite. Their red cells have both A and B antigens, so their immune system recognizes both as self.
Which means their plasma is totally clear.
Totally clear of anti-A and anti-B antibodies. There are no weapons waiting in the plasma. So you can give them A, B, O, or AB red cells, and their body just accepts them. This immunological tolerance gives them a huge advantage in a transfusion scenario.
And the other two, A and B, they just follow that same logic. Group A has the A antigen, so their plasma arms itself with anti-B.
And Group B has the B antigen, so they carry anti-A antibodies. It's a beautiful, simple system of perpetual surveillance, and we really have to dwell on the consequences here.
The consequences of getting it wrong.
Yes. The risk of transfusing ABO incompatible red cells, say giving Group A cells to that Group O recipient we mentioned, it's not a minor problem. It is an all-out immunological war inside the patient's body.
Okay, let's walk through that mechanism. I think it's really important for our listeners to understand why that never use column is so absolute. What actually happens step by step when those incompatible cells meet those pre-existing antibodies?
The meeting is instantaneous, and it's dramatic. The antibodies in that Group O plasma will immediately lock onto the A antigens on the donated cells. This triggers what we call severe red cell hemolysis.
Hemolysis, so the cells are literally bursting open.
They are being destroyed, ruptured on a massive scale, and it's that cellular explosion that kicks off a full systemic collapse.
So it's not just that the body is rejecting the blood, it's the debris from those destroyed cells that's now flooding the system.
Precisely. The cellular contents, the hemoglobin, all of it. It immediately initiates something called complement activation. Complement is this cascade of proteins in your blood that basically amplifies the inflammatory response.
So it turns a local mismatch into a body-wide five-alarm fire.
That's a great way to put it. The patient very quickly goes into a state of shock. Their blood pressure plummets, and their tissues aren't getting enough oxygen.
And the kidneys are often the first major organ to take a hit.
Yes, the kidneys just get overwhelmed. They're trying to filter out all this debris from the destroyed red cells. The renal tubules, the tiny filters, they get clogged and they just shut down. You get acute renal failure.
But the outcome listed in the source material that seems the most terrifying, the one that really signals a total loss of control, is disseminated intravascular coagulopathy, DIC.
DIC is, it's the ultimate paradox of systemic failure. That massive inflammatory response triggers the body's entire coagulation system to go into overdrive. Everywhere, all at once.
So you're forming tiny clots all through the bloodstream.
Tiny clots, microthrombi, in the smallest vessels. In the brain, the lungs, the kidneys, it's like all the tiny pipes in the body are getting clogged simultaneously. And in the process, the body uses up all of its clotting factor.
It burns through its supply.
It completely exhausts the supply of platelets, of fibrinogen, everything you need to form a clot. And once those are gone, the patient loses the ability to clot anywhere. So you get this horrifying situation where they're clotting uncontrollably in some places and bleeding uncontrollably from everywhere else.
A simultaneous clotting and bleeding crisis.
Yes, and it has a very, very high mortality rate. The entire chain reaction from that simple ABO mismatch to DIC and death can happen incredibly fast. That's why ABO compatibility isn't just important, it is the absolute bedrock of transfusion safety.
Okay, so once we have that foundational ABO compatibility sorted, we can then shift our focus to the second major player here, the Rh factor, and specifically the D antigen.
Right. The D antigen is the most significant, the most immunogenic of all the different antigens in the Rh system, and it requires its own set of very strict rules.
The definition is simple enough. If the D antigen is present on your red cells, you're D positive. If it's absent, you're D negative.
Exactly. And the source material gives us some context here. In the Australian population, for instance, about 84% of people are D positive, which leaves about 16% who are D negative.
Which right away creates a logistical challenge for blood banks, but more importantly, it creates this critical safety issue.
Absolutely. The D negative people are the vulnerable group here. Their safety really depends on avoiding any exposure to that D antigen. And the reason why is that the D antigen is labeled as highly immunogenic.
So let's clarify that. We talked about how ABO antibodies are naturally occurring. They're just always there. The D system works differently.
Fundamentally different. Anti-antibodies do not occur naturally in D negative people. They're only formed after a D negative person has been exposed to the D antigen.
So through a transfusion or an organ transplant.
Or, and this is the most critical one, during pregnancy. So this means if a D negative patient gets D positive blood for the very first time, they might not have that immediate catastrophic reaction we saw with ABO. But they will almost certainly develop anti-D antibodies. They become what we call sensitized.
And once you're sensitized, that's permanent, and the risk becomes twofold.
It is permanent, yes. The first risk is acute. If they ever receive D positive blood again after being sensitized, they will have a hemolytic transfusion reaction. Maybe a bit delayed compared to ABO, but still very dangerous.
Okay, but you said the more profound risk is the long-term one, the intergenerational one.
That's right. And it's all centered on women of childbearing age. And we're talking about something called hemolytic disease of the fetus and newborn, or HDFN.
Can you break down how that works?
Of course. HDFN is a condition where the mother's immune system essentially attacks her baby's blood cells. So imagine a D negative mother is carrying a D positive baby. During pregnancy, or more commonly during delivery, small amounts of the baby's D positive blood can cross the placenta and enter the mother's circulation.
And that's the exposure event. That's what sensitizes her.
That's the sensitizing event. Her body sees this foreign D antigen for the first time and starts producing permanent anti-D antibodies. Now, here's the crucial part. These anti-D antibodies are specific type, IgG, which are small enough to cross back through the placenta.
So the first D positive baby is usually okay.
Right. The first pregnancy often just serves to sensitize the mother, but it's the second and any subsequent D positive baby that faces the real danger.
Because those maternal antibodies are now in her system, ready to cross the placenta and attack the new fetus's red blood cells.
Exactly. And those antibodies will destroy the developing fetal red cells, leading to severe anemia in the fetus. This can cause jaundice, brain damage, even fetal death. It can require really complex and risky in utero blood transfusions to save the baby.
Which is why the guidelines are so incredibly strict on this point.
It's a non-negotiable rule. D-negative females of childbearing age must receive D-negative red cells, period. It's the pinnacle of proactive medicine in this field. We have to prevent that sensitization from ever happening.
Because once that anti-D antibody factory is built, you can't tear it down.
You can't. And the clinical cost, not to mention the emotional cost, of managing HDFN is just too immense when prevention is so straightforward.
Now, we should touch on some of the special cases mentioned in the source material. Why would a D-positive recipient sometimes need D-negative blood? You see things like hematopoietic stem cell transplant or extended matching for sickle cell disease.
Right, that's where we move beyond just simple ABO and D. For a patient with sickle cell disease, for example, they might receive hundreds of transfusions over their lifetime.
So they're exposed to a huge amount of foreign blood.
A massive amount. And while D is the most potent antigen, their bodies start to react to other less common antigens in other blood group systems. So they need what's called extended phenotype matching to prevent them from developing multiple antibodies, which makes finding compatible blood almost impossible down the line.
So for them, giving D-negative blood, even if they're D-positive, is just about giving them the cleanest, least reactive product possible to minimize that overall antigen load.
That's it, exactly. And for a stem cell transplant, you're essentially resetting the patient's entire immune system. The new immune system from the donor might react to all sorts of things. So again, you want the cleanest, most tailored blood products possible during that transition.
So to sum it up, for most D-positive people, D-positive blood is the standard. But for D-negative people, exposure to D-positive blood is a serious medical event with lifelong consequences.
That perfectly captures the fundamental asymmetry of the RH system.
Okay, so we've established the biology, the life or death importance of ABO, the specific risks of RHD. Now let's get into the tactical application, the compatibility tables. This is really the instruction manual.
It is. This is where the rubber meets the road. It's what allows a clinician in a moment of extreme urgency when maybe the patient's group isn't confirmed or when stock is low to make a calculated, safe decision.
Let's start with red cells, since they carry that primary immediate ABO risk. The golden rule here seems to be avoid mixing those antigens with those pre-existing antibodies. So let's start with the Group O patient, the strict recipient.
For a Group O patient, there's no flexibility. Their best option is O red cells, and it's also their only option. A, B, and AB are all squarely in the never-use column.
Because their plasma has both anti-A and anti-B.
Right. Any substitution leads to that explosive hemolysis we talked about. No wiggle room.
Now, contrast that with the universal recipient, Group AB.
Group AB is the most flexible. Their best option is, of course, AB cells, but it's okay to use O, A, or B.
Because their plasma is weapon-free.
Exactly. No antibodies waiting to attack.
Right.
They can receive any red cell type without that immediate ABO reaction. In a major trauma, if you know the patient is AB, the logistics suddenly get a lot simpler.
And A and B patients fall in the middle. They can use their own type, or they can fall back on Group O.
That's it. Group A can use A, which is best, or O, which is okay. Group B can use B, best, or O. Okay. The Group O red cell, because it lacks the A or B antigens, acts as that ultimate backup, the clean slate.
Which brings us to the big emergency exception, the trauma scenario. A patient comes in, you have no idea what their blood type is, and every second counts. The best option is listed as O negative.
O negative is the true universal donor. It's ABO compatible with everyone, and critically, it lacks the D antigen, so it's also RH compatible with everyone.
Yeah.
It's the safest possible product to give in the dark.
But O negative is also the rarest. It's often in short supply. And the guidance brings up this scenario where O negative just isn't available. The rule then says, O positive red cells may be given, but to male patients only.
And this is a profound clinical calculation. It's risk management in real time. If a patient is bleeding out and is going to die without blood, you have to weigh the immediate risk of death against the future risk of sensitizing them to the D antigen.
Because O positive blood carries that D antigen.
It does. Giving it to a D-negative person will almost certainly sensitize them. But if that D-negative person is male, that sensitization carries no risk of HDFN to a fetus.
So you're making a trade-off.
It's saving their life now while knowingly accepting a future complication, the fact that they now have anti-D antibodies.
Yeah.
It's an acceptable trade-off when the alternative is immediate death.
But what happens to that male patient down the road? If he needs another transfusion 10 years from now and he's been sensitized, isn't he now in a much tougher spot?
He absolutely is. Once sensitized, he can only receive D-negative blood for the rest of his life. It's critical that the blood bank keeps a detailed record of this event to prevent him from ever getting D-positive blood again.
Because a second exposure would trigger a major reaction.
A delayed, but very severe hemolytic reaction. So yes, it creates a permanent new complexity in his future medical care. But it's a complexity we accept to avoid mortality. And building on that, let's look at the specific D-compatibility rules.
Okay, so for a D-negative recipient, the best option is D-negative blood. D-positive is listed as never use, but with that huge asterisk we just discussed for the male emergency.
Correct. And for D-positive recipients, it's simpler. D-positive is the best option, but D-negative is perfectly okay to use.
Because a D-positive person already has the D antigen, so giving them D-negative blood, the clean slate, is totally safe.
It's perfectly safe. It's just not ideal from an inventory management perspective because you're using up a precious resource on someone who doesn't strictly need it.
Let's go back to that emergency asterisk for a second. If a D-negative male does receive D-positive red cells, the guidance says you have to do strict post-transfusion monitoring. It mentions 2 specific tests, DA and BGAB. What are those checking for?
This monitoring is absolutely essential. The DAT, which is the direct antiglobulin test, is checking for the immediate problem. It looks at the red cells currently in the patient's circulation to see if they're already coated with antibodies.
So it's looking for active destruction.
It's checking to see if hemolysis is already underway. It's the acute event check.
And the BGAB test.
BGAB is blood group antibody testing. This is the test that looks for the long-term consequence. It checks the patient's plasma to see if they have, in fact, developed those new anti-D antibodies.
So it confirms if sensitization has actually occurred.
Exactly. It's usually done a few weeks or months later, and it confirms that the trade-off we made was real. And it ensures that patient's medical record is flagged forever. Without that follow-up, you're putting them at huge risk for any future transfusions.
Okay, so we covered red cells. Now we switch to platelets, which are for clotting, and this is where the D antigen becomes this really subtle but high-stakes problem.
This is a critical point and one that often causes confusion. The platelets themselves do not actually carry the D antigen.
Right, but
the platelet components are never perfectly pure. They always contain a small, residual amount of red blood cells from the donor. We call them hidden red cells.
And those red cells carry the D antigen if the donor was D positive.
Exactly. So even though you're giving a platelet transfusion, that trace contamination of red cells means the risk of desensitization is still there, especially for that high-risk group we keep talking about.
D-negative females of childbearing potential.
Right. Giving them D-positive platelets could sensitize them for life. So the source material outlines the solution. If you must give D-positive platelets to this high-risk group, you must also consider giving RHD immunoglobulin prophylaxis.
Okay, let's explain how that works. What does RHD immunoglobulin actually do?
Think of it as a preemptive strike. RHD immunoglobulin is basically a shot of preformed anti-D antibodies.
So you're giving them the antibody?
You are. And those injected antibodies circulate and immediately find and bind to any of those stray D antigens from the hidden red cells in the platelet bag. They neutralize them before the recipient's own immune system even gets a chance to see them and start building its own permanent antibody factory.
It's like a temporary sacrificial shield.
That's a perfect analogy. It's a phenomenal piece of preventative medicine.
Okay, so that's the D antigen risk with platelets. But now we have to talk about ABO compatibility for platelets, which is even more confusing. Because now the danger isn't the platelet itself, it's the plasma that the platelets are suspended in.
Exactly right. For platelets, we're less worried about the antigens on the platelet surface and far more concerned with the antibodies in that small volume of plasma that comes along for the ride.
So if you give platelets from a Group O donor to a Group A recipient,
the plasma in that Group O unit contains anti-antibodies. And those donated anti-antibodies can attack the recipient's own circulating Group A red cells.
Which is why the guidelines are always talking about using low-titer products.
Precisely. Low titer just means a low concentration of those antibodies. If you have to give a non-ABO identical platelet unit, you need to be sure the contaminating antibodies in the plasma are too weak to cause significant harm.
Let's look at the table because it really shows this balancing act. For a Group O recipient, O platelets are best. A platelets are listed as okay to use, but B and AB are avoid if possible. Why?
Well, the goal is always to minimize introducing foreign antibodies. It's a complex calculation of risk. The thinking is that the anti-B antibodies in an A unit might be less problematic for an O recipient than, say, the plasma components in a B or AB unit. It gets very nuanced.
And for a group A recipient, A is best, O and B are okay, but AB should be avoided. Now that's weird. AB plasma has no antibodies, so why would AB platelets be avoided for an A patient?
This is where we see two competing priorities: the red cell safety from the plasma and the platelet function. The guidance often prioritizes matching the platelet antigen itself to maximize the lifespan and effectiveness of the platelets. An A patient's immune system might clear AB platelets faster than it would clear A platelets.
So you're balancing the risk of hemolysis from the plasma against the benefit you get from the platelets themselves.
You're balancing red cell safety with platelet efficacy. It's a constant juggle.
And the final logistical note, AB platelets are the best option for group AB patients, but are noted as not routinely available.
And that's just the reality of inventory. Group AB is the least common blood type. So trying to keep a stock of a rare product for a population that can already accept any red cell type it's a huge challenge.
Okay, deep breath. Now we move to plasma components, fresh frozen plasma and cryoprecipitate. And before we even look at the table, we have to emphasize the rules completely invert here.
You have to mentally flip a switch. With red cells, we care about the antigen flags on the donated cell. With plasma, we're giving a bag of fluid full of antibody weapons.
And we have to make sure those donated weapons don't attack the recipient's own cellular flags.
Exactly. And the most significant difference here, the Rh factor is irrelevant.
Irrelevant, why?
Because D antigens live on red cells. Plasma is the fluid part of the blood. It's a cellular. There are no red cells, so there are no D antigens, which means no risk of desensitization. You can give plasma of any D type to a recipient of any D type.
Which is a huge simplification. This also means the roles of universal donor and recipient are flipped on their head. Group AB, the universal recipient for red cells,
Now becomes the universal donor for plasma.
that's the key takeaway.
It is. AB plasma is the best option for an unknown patient or for any patient group. Why? Because the plasma from an AB person contains no anti-A or anti-B antibodies. It is weapon-free fluid. You can give it to anyone